So good morning, everyone. Welcome to this tricuspid valve session at the Society meeting. Unfortunately, Massimo won't be able to join us and won't be able to give his talk as he had to operate last minute. So this session has been curtailed to the two talks from Abbas and from Karen. And I very much look forward to hearing from both of them. So shall I hand the microphone over to Abbas, please? Abbas, are you there?
Yes, I'm here. And you see, excellent. Good morning, everyone, and thank you very much for the invitation and the opportunity to present at the society meeting. It's a huge privilege, and I'm hoping
Abbas,
the next.
Can you hear us?
Yes, I can hear you. Can you hear me?
Hello.
Hi, can you hear me? Hello, can you? Hi, can you hear me? Can you hear me now?
Abbas?
Yes.
Abbas, can you hear us?
Yes,
I can hear you. Can you hear me yet? I'm not sure.
Yes, we are able to hear you, Abbas.
Fantastic. So I'm just going to introduce myself. Good morning, everybody, and thank you for this excellent opportunity to be here at the society meeting, and the opportunity to present on the tricuspid valve imaging.
Apologies for these technical issues this morning, but hopefully we can get the session started any minute.
Fantastic. Okay. So just to give you a brief introduction, I'm Abbas Krishnud, one of the consultant pediatric cardiologists at the Freeman Hospital in Newcastle. And I am a transplant physician. My special area of interest is congenital transplant medicine and cardiac MRI. And I'm looking forward to this discussion.
Hello.
Valve imaging after my presentation.
Hi, Sunil.
Enjoy that. Thank you. Are you able to run the presentation?
Oh, you can. Oh, because I can't hear anything.
Hello, everyone. Thank you for the invitation to talk on tricuspid valve imaging at the conference today. A huge topic. I'm hoping I'll be able to cover the important elements in the next 15 minutes or so. To begin with, I would like to talk a bit about the facts and anatomy of the tricuspid valve and swiftly move over to the imaging modalities that will allow pre- and post-operative assessment of patients undergoing tricuspid valve surgery. I would like to finish off with some key learning points, taking into account one of the case studies at our center. So why the tricuspid valve? Historically, it has been considered as a forgotten valve. Even T.W. King in 1837 designed and said that it was meant to become incompetent. But we have now recognized that the disease from the tricuspid valve is increasing, and tricuspid regurgitation is one of the most common manifestations. The burden or the long-term effects of tricuspid valve disease are better understood, and using multimodality assessment of the tricuspid valve, we can understand that better with a view to focus on surgical interventions. So this renewed interest in the tricuspid valve is clearly apt, and I can use this example here to demonstrate that. So if Prince William here is the mitral and aortic valve, we have Prince Harry, the tricuspid valve, and certainly he feels so lucky having us with him. Jokes apart, we do understand the risks and benefit that tricuspid valve surgery can bring, but early intervention has shown to improve outcomes. So let's begin with describing the tricuspid valve anatomy. You can clearly see that it's a complex entity, a thin fibrous tissue with a saddle-shaped annulus. It comes with 3 leaflets, anterior, posterior, and septal, and a subvalvular apparatus with chordae tendineae and papillary muscles, as shown in the cartoon on the left, with the anterior, septal, and inferior muscles. The fibrous annulus has a large area of 7 to 9 centimeters for coaptation, making it the largest valve in the heart. The other finding is that it's vertical and orientated 45 degrees to the sagittal plane, and this becomes quite important when performing transesophageal echocardiography because it can make identifying and visualizing the leaflets difficult when compared to the mitral valve. It has valve margins anterior superior, inferior, and septal, and it comes with 3 commissures. So when we talk about risks and benefit of tricuspid valve surgery, this data from 2017 shows why the surgical community are a bit wary of performing isolated tricuspid valve surgery. It comes with a high mortality between 8 to 10%. But I suppose the story for congenital heart disease and tricuspid valve surgery is slightly different. So here is the data from UK National Audit Database in pediatric cases from 2014 to 17. And this is from 13 centers taking about 149 cases. Similarly, we've got data in the ACHD population from 21 centers nationally. And in both cases, we can clearly see that the survival at 30 days is more than 95% in most centers or around it, making a very good case that the tricuspid valve surgery results in the congenital population are very different to the functional tricuspid regurgitation. This is the Freeman data, which shows that we took more than 35% cases for tricuspid valve procedures when in a total of all valves for surgery. And if I break this down into pediatric and ACHD for isolated tricuspid valve disease, we have about 20% patients in pediatrics, which 10 patients out of the 54 that underwent isolated tricuspid disease repair. Similarly, a high number in the ACHD cases as well. So how would you classify etiology on the basis of tricuspid valve intervention? Now, the common one, as seen in a lot of articles and publications, is a primary and secondary division. I feel that for the purpose of this talk, I've divided the tricuspid regurgitation into functional and organic. Functional being the left heart disease and RV dysfunction with various causes related to it, and organic being congenital, endocarditis, degenerative, rheumatic, and carcinoid. And the purposes for our patients especially, we would be focusing on congenital endocarditis and trauma either through rupture or pacemaker leads. And within the congenital population, Epstein's and dysplastic tricuspid valve form the major element of it. So how does multimodality imaging help with making pre-surgical decisions? So the main aim is to try and find the pathophysiology for the tricuspid regurgitation, pre-procedural planning as a result of that, and then monitoring both intra and post-operatively. And I think everyone would agree that echocardiography is the cornerstone imaging modality for the tricuspid valve, both in form of transthoracic and esophageal. You can take 2D or 3D imaging here, and we do agree that cross-sectional imaging does come, and in this day and age, one cannot completely be shy of it, and therefore CT and MRI do have their place. What we're trying to achieve here with the imaging is to get a qualitative understanding of the tricuspid valve lesion, both through looking at the morphology of the leaflets, subvalvular apparatus, and the right heart structures. More so quantitatively, we are also looking for the degree of regurgitation, the effective surface area, and RV function with the right heart pressures. So for a surgeon, what are we providing in terms of imaging? And here you've got a 2D and 3D image of the tricuspid valve. And for the surgeon, the question is whether they can repair the valve or would they need to replace it? And that brings back to the basis of identifying the morphology and the evidence of the lesion, which will allow the surgeon to make that decision. So if you take these two important elements into factor for imaging, the anatomy would be described for the leaflets, the annulus, and the papillary muscles. We would look at right heart volumes and coronary arteries as anatomical relationships. And from a functional point of view, we'd be looking at the degree of regurgitation, right heart function, and evidence of right heart pressures. And you can clearly see that all modalities will provide some sort of information, but echocardiogram clearly leads on all fronts. And this paper from Lancelotti in 2013 clearly shows that echocardiography provides the important information that we require for prior to a tricuspid valve repair. So I would like to talk a bit about 3D echocardiography, as it seems to be the way forward for describing lesions on the tricuspid valve. The main two reasons why this has become such a cornerstone is better spatial imaging and quantitative assessment. Through 3D echocardiogram, you can get an en-face view, which allows you to see the surface of the tissue very well, and also allows you to be able to do that in real time or in a reconstructed manner. The imaging allows you better quantification with no geometric assumptions, area measurements, and volumetric and mass assessments as well. So all in all, 3D echocardiography gives both real-time and reconstructed imaging, which defines the tricuspid valve very well prior to surgery. So for the surgeon, if you're looking from the right atrium in a surgical view, this is how the 3D echocardiogram would show. And if you're looking from the right ventricle, you would still be able to see the 3 sept leaflets in the same way a surgeon would like to see. So if you start with 2D echocardiography, it gives you a good feeling of the degree of regurgitation, both visually and quantification-wise. You can see the right heart dilatation, and if there is a degree of septal or leaflet prolapse, and that would be well evident. But more importantly, you can get that in a very realistic manner from a 3D imaging. The next few slides will just give you an update on different conditions using 3D echocardiography. So here we've got the Epstein's anomaly of the tricuspid valve. On the left, you can see the atrialization with the septal displacement and anterior leaflet displacement of the epsteinoid valve. And this en-face view gives all the 3 leaflets in that position. On the right, you've got a cine, which gives you an information of where the attachments are of each leaflet and the degree of lack of cooptation, which can cause regurgitation in this valve. So the next one is tricuspid valve endocarditis. And here we've got an example of an oncology patient with a large vegetation as shown in the white arrow. And you can see in a cine moving image how the vegetation is causing restriction and limitation of the leaflet movement. The next example here is of a damage to the tricuspid caudal tissue. This is a patient who is post-cardiac transplant and underwent an endomyocardial biopsy. Following the biopsy, there was traumatic trauma of the leaflet of the tricuspid valve. And here you can see the septal leaflet in the en-face view on a 3D imaging. Finally, more commonly also seen is a pacemaker lead, which is being used in the tricuspid valve. And here you can see a patient where the lead is interfering with the septal leaflet motion of the tricuspid valve. So clearly, 3D echocardiography has provided the imaging expertise that a surgeon would require. Cardiac CT, on the other hand, has allowed us to demonstrate the anatomical correlations within the heart and also give accurate measurements as necessary. And in this image, you could see that the right coronary artery coming out and it's through the AV groove and its relationship to the tricuspid valve. So certainly CT scan adds on to the information provided by 3D echocardiogram. The cardiac MRI is also quite useful, not only for functional assessment, but also to see the movements of the valves and the degree of regurgitation. Here we can see in this red arrow the anterior leaflet, and in the yellow arrow the septal leaflet, and the degree of lack of cooptation causing the regurgitation. In the cine at the bottom, we can see the functional assessment of the right heart and the degree of regurgitation through the tricuspid valve. So cardiac MRI has its role in supplement to the echocardiogram. And future technologies are coming through for cardiac MRI with 4D flow. And you can see here in this cartoon where you can see the flow streams and allow us to get better assessment both of the tricuspid regurgitation and the degree of surgical intervention that can be provided. So post-surgery, what are we looking for? So before the surgery, we were thinking about whether it's going to be a repair or a replacement. Post-operatively, we are thinking whether there's going to be residual regurgitation or some degree of stenosis. And the important thing is what is acceptable. So here is just some echo images of both pre and post-operative repair following an Epstein's anomaly surgery. We also have to remember that RV function becomes an important element of post-surgical assessment. So I think the key question post-surgically is this repair acceptable given the degree of issues? And we'll be able to demonstrate that with this case study here. So I would like to complete my talk by this case study. In 2018, a little baby was born with a condition of CCTGA and a severe Epstein's anomaly. So you can see a severe degree of regurgitation through the Epstein's wall, and the local team at 6 months of age decided to go ahead with a pulmonary artery band. The patient was quite stable for about a year, and then in 2019 they realized that the degree of regurgitation from the epsteinoid wall is worsening, and the RV function was also getting impacted. They performed a cardiac catheter in 2019, and the numbers at the point seem reasonable. The decision then for the local team was whether to do nothing, list this patient for transplantation, or take a high-risk strategy to do one of the two surgical interventions listed here. It was a difficult decision, and hence the local team went to seek three opinions, whether to go for transplant or surgery. Though the majority of the opinions came back for a transplant assessment and assessing for candidacy, the team felt that they would like one more further opinion, and hence the child was referred to Newcastle. Reviewing the original data, which was in the beginning of 2020, we felt that we needed to repeat another cardiac catheter and then decide what would be the best intervention. So in March 2020, the child had a cardiac catheter, and the data as shown is very reasonable with a TPG of 9, and hence the child was pretty much suitable for any form of approach. On discussion at the JCC towards the end of March, we knew that the child is asymptomatic at home with some degree of RV impairment and severe tricuspid regurgitation. We felt that listing the child for transplantation was a bit too soon, and on a routine list at that age, the likelihood of getting a transplant are going to be very slim. Hence, we took a high-risk strategy to go ahead with a double arterial switch and a cone repair. So in July 2020, the child ended up having a double arterial switch with the cone repair of the Epstein's valve. The outcome was great. The child really made very well post-operative recovery and was transferred back to the local center to be discharged soon after. And since then, the child remains very well. So this imaging in 2D echocardiography shows the tricuspid valve, which is epsteinoid and severely regurgitant. This is preoperatively. The child then went for surgery, and this is the post-surgical outcome with good function and acceptable regurgitation through both the right and the left valves. So here is a video of the regurgitation preoperatively, and this is comparing it postoperatively. So it goes to show that even in complex cases, the outcomes are reasonable, and the key of imaging is to provide an answer which would provide an acceptable yet a very good outcome for the patient. So in the end, I would like to sort of clearly say that, in summary, a comprehensive understanding of the pathophysiology using imaging techniques is very important for defining any surgery for the tricuspid valve. We need to understand that the tricuspid valve is an interplay between complex anatomies, structures, and RV function with a lot of loading conditions. The key points from this talk I would like to end with is that echocardiography is the primary non-invasive modality for assessing patients with both pre- and post-operative tricuspid valve disease, and the accuracy of multimodality imaging is key to successful outcomes. Thank you very much for listening to me, and I'm very happy to take in any questions. Thank you.
Thank you very much, Abbas. That was an interesting talk. I will first give the floor, the audience, the opportunity to ask any questions. Is there anyone who would like to put a question to Abbas? I see there's a few more attendees now. Okay, Abbas, can you hear me?
Yes, I can. Can you hear me?
In case you can hear me, could you elaborate a little bit more about what you think the role of MRI scanning versus echo is as far as assessing repairability of the tricuspid valve? You touched a little bit on that, but could you please elaborate a little bit more, please?
Absolutely. Can you hear me? In the audience, I'm not sure whether Andres can hear me, but I'm not clear whether everyone else can either.
Can you hear me now?
I can hear you, but I'm not sure whether you can hear me.
Sorry, I'm struggling hearing anything. I'm not sure if you can hear me.
I can hear you. Can everyone hear me? Should I just...
Yes, we can hear you, and the attendees can hear you, but they cannot answer by voice.
Okay, that's great. So I will answer the question. So thank you,
Could
Andres.
maybe send me a message. Sorry, I'm struggling hearing anything here.
Can you hear me now? So I'm going to try and attempt to answer this question, and maybe
Okay.
if not, probably come back later again. So in response to your
I'm
question...
sorry, I'm struggling here trying to moderate this. Okay. Okay, if you can I don't think I can hear anyone, but what I'll suggest you do is if you can just answer any question that people pose to you, Abbas, and then send me a text when we can progress to the next talk. We can give you another couple of minutes. Okay. So I believe there is no question. In which case, I will ask Karen, who is the lead surgeon in Leeds, as you all know, who has an interesting topic that we don't talk much about nowadays, but I very much look forward to hearing what her views are on tricuspid valve surgery in non-Epsteinoid valves or non-Epstein anomaly valves, because we do discuss this from time to time, and it does impact our clinical practice quite significantly. So, can I give the floor to Karen, please? Thank you.
So as already said, it's an interesting topic, and we don't talk a lot about it. And the presentation, I think, should come up very shortly, and probably let it run, and then we can discuss afterwards. Hello, my name is Karin van Doorn, and I'm a cardiac surgeon from Leeds. I thank the Society for the invitation to present this lecture on non-Epstein tricuspid valve repair or replacement in adults with congenital heart disease. The contents of the lecture will cover the definition, underlying mechanisms, the incidence, the indications for surgery, surgical techniques, outcomes, and decision-making. In the context of this lecture, the definition of non-Epstein tricuspid valve disease is a condition that affects the function of the inlet valve between the atrium and the right ventricle. We assume that there is a biventricular circulation with an adequate sized tricuspid valve and right ventricle, and that the right ventricle is the subpulmonary ventricle. The incidence of this condition is not known. The tricuspid valve is the forgotten valve and usually not systematically studied, and papers generally only report series of operated patients, but without the denominator, i.e. without saying what the total population is. However, with longer survival in adult congenital heart disease, tricuspid valve failure is increasingly recognized as a problem. So what about the indications for surgical intervention? Well, in spite of a recent update on the guidelines for the management for adult congenital cardiac conditions, there are no evidence-based guidelines for the surgical management of tricuspid valve disease in this population. Current indications for surgery are often based on extension of guidance for the treatment of tricuspid valve disease in non-congenital patients, and this may or may not be appropriate. So in the absence of guidelines, we have to go back to basics and ask what are actually the principles used to develop the guidelines in the first place. For this, we need to know the etiology, and as surgical intervention aims to relieve either symptoms or improve longevity, we need to know what the symptoms are of the patients, and also if there are any other signs other than symptoms that may indicate a worse outcome. We need to quantify the severity of the valve disease, identify treatment modalities, and decide how the pros and cons of treatment weigh up. The etiology of tricuspid valve disease in adult congenital heart disease can be split into primary and secondary. The primary structural disease involves congenital disease with quite often leaflet and subvalvular apparatus thickening, as we, for example, see in pulmonary atresia and intact ventricular septum. Secondary tricuspid valve failure is much more common. This is either acquired structural disease related to injury at the time of either cardiac surgery or percutaneous intervention or by pacemaker wires, or as a result of endocarditis. Tricuspid valve failure can also result from annular dilatation and distortion of the geometry of the valve, and this generally is related to long-standing elevated loading conditions of the right heart, which can either be volume loading with a left to right shunt, for example an ASD, or pressure loading with elevated right ventricular pressure, either at the level of the right ventricle, the pulmonary vasculature, or it may be due to left heart disease. So what about the symptoms in tricuspid valve disease? And this is generally tricuspid regurgitation. Tricuspid stenosis is very, very rare. Severe tricuspid regurgitation may be tolerated for very long periods of time, in spite of advancing right ventricular dysfunction, but with very little symptoms, only to be discovered during cardiac imaging. This will ultimately lead to atrial fibrillation, right heart failure, and premature death. If symptoms emerge, there is severe right heart failure, and patients are dyspneic, fatigued, have an enlarged and painful liver, and lose appetite and lose weight. Many of the tricuspid valve problems are actually related to other causes that cause increased loading of the heart. So it may well be the symptoms of the index cardiac problem that will be presented by the patients. So purely looking at tricuspid valve regurgitation, symptoms present late, so we need to look for other indicators for the severity of tricuspid valve disease to guide us for surgical intervention. And of these other indicators, it is particularly known that an increase in size of the right ventricle and a decrease in function are related to poor survival. So what are we doing to image the heart to help us look at these elements? Cardiac echo is really, really good to look at the morphology of the tricuspid valve and the annular diameter as a measurement of size. But for right ventricular volume measurements, MRI is much more useful. Both echo and MRI give us estimates of cardiac function. However, if there is secondary functional tricuspid valve failure, it is also important to look at the rest of the cardiopulmonary circulation to identify those lesions which are the index lesions that cause the functional tricuspid valve disease. We also need to look at interaction between left and right ventricular function. For further diagnostic measurements, we can use cardiac catheters, a cardiac catheter for direct pressure measurement in the heart and for coronary imaging. CT can also be used for this. And finally, EP studies are also important. If we're interested in assessing the right ventricular function in more detail, then it is important to realize that a lot of the earlier imaging studies are all performed at rest. And what we really are interested in is what the cardiac reserve is. And rest measurements may not be representative for this. So more recently, cardiopulmonary exercise testing has shown that reduced right ventricular reserve may be an independent predictor of mortality. And importantly, this can be present prior to the onset of symptoms or prior to the onset of resting right ventricular dysfunction. Even more detailed assessment of the right ventricle was recently done in non-congenital cardiac patients using multimodality imaging studies with cardiac catheter and echo. And this showed that it was possible to study right ventricular contractile function independent from cardiac loading. Other useful parameters of assessment of right ventricular function or cardiac function in general, such as BNP, the value of those biomarkers in right heart failure still remains unclear. The available treatment options for patients with tricuspid valve disease fall into medical management, percutaneous intervention, and surgery. Medical management is usually important to reduce the loading conditions of the heart, for example, pulmonary hypertension, or to treat heart failure. Percutaneous intervention has no established role for native tricuspid valve disease, but is increasingly used for valve-in-valve treatment of failing bioprosthetic valves. Percutaneous intervention can be useful to treat the index lesion that causes secondary tricuspid regurgitation. For example, the closure of an ASD percutaneously will reduce the volume load. Interestingly, functional tricuspid regurgitation often improves early after intervention, but rarely totally disappears. And frequently there is residual moderate TR present in the longer term. Surgical intervention has the option, has the possibility to deal both with the structural parts of the valve, or if the valve is not repairable, replace the valve. The repair of the tricuspid valve can be quite challenging. It is a complex organ. It runs in 3 dimensions. And actually there is also a 4th dimension because the tricuspid valve area is actually changing during the cardiac cycle. So what is the armamentarium that surgeons have for the treatment of tricuspid valve disease? There are many tools that are available, but the importance is that the guidance for the type of repair is provided by an understanding of the mechanism for the tricuspid regurgitation. If the mechanism involves the structure of the leaflet and subvalvular apparatus, then generally valve repair techniques, including chordal and papillary muscle procedures, cleft closures, etc., can be applied. Increasingly, rings are used to stabilize these repairs, and permanent pacing leads need to be excluded from the orifice of the functioning tricuspid valve. This slide depicts a number of repair techniques where either the orifice is supported and reduced, or a leaflet is augmented, or the subvalvular apparatus is supported. In case of amyloid dilatation, it is the free wall of the right ventricle that dilates in an asymmetrical way. So a valve ring will address this and bring this free wall back into the normal plane. If the valve cannot be repaired, then there is tricuspid valve replacement, and this shows a bioprosthetic valve. Both for the tricuspid repair and replacement, it is important to have a good understanding of the cardiac anatomy, because particularly the AV node, the coronary sinus, and the right coronary artery are at risk of injury. And if there is heart block post-op, it is useful to consider an epicardial pacing system, so there is no risk of injury to the tricuspid valve from the endocardial pacing lead. For the outcomes of tricuspid valve surgery, we have to rely on retrospective single-center studies, as there have been no randomized prospective controlled trials. These studies, and more have been emerging over the last few years, show that isolated tricuspid valve operations are infrequent, and guidance on the incidence and timing are lacking. Most of the patients that undergo tricuspid valve surgery in the adult congenital population do this as a concomitant procedure at the time of surgery for another cardiac lesion. And if the tricuspid valve is addressed at this time, then it has been shown this has a better survival. This type of surgery takes place in 3 to 10% of the adult congenital operations. Importantly, for these concomitant tricuspid valve procedures, it is important to make a decision to operate prior to surgery, as the conditions of anesthesia reduce the TR that is seen in the operating room. Outcomes for valve repair are superior compared to those for replacement. And although repair should be aimed for, the most common reason for not doing so was lack of pliable tricuspid valve tissue. In spite of favorable outcomes from repairs, over a third of the patients developed moderate recurrent TR at follow-up to 45 years. And increasingly, stabilization with a prosthetic ring is used, which guarantees a lower postoperative recurrence. And the use of a ring has a much better outcome than that of the historical suture annuloplasties. If a valve replacement is performed, then biological and mechanical valves have an equal survival up to 5 years. On the whole, the mortality associated with tricuspid valve surgery is low and is especially guided by the index procedure. However, if there is severe right ventricular failure, then getting a handle on the right ventricular reserve is important but very difficult. In a lot of the concomitant tricuspid valve operations, this involved redo surgery, and this may carry a risk, particularly for access. And not just looking at the valve, but at the whole patient, there are no established risk scores to look at the comorbidity. So there is a need to assess end organ function, particularly the liver, the pulmonary vascular bed, and the kidney, and with a growing older population, also increasingly frailty. So, as there is an awful lot of lack of evidence, how do we come to reliable and reproducible decision making for the indication and timing of surgery? The best way forward is to do this at multidisciplinary meetings, and these should involve experts in multimodality imaging, and there should be access to longitudinal observations on these valves. As many patients are asymptomatic, the size and the function of the right ventricle should be carefully considered. And as there are no risk scoring system in isolated tricuspid valve surgery, it is really important to look at comorbidities and also look at the available surgical expertise. However, if the patient has an indication for cardiac surgery for other cardiac pathology, the threshold for tricuspid valve surgery should be low. With increasing experience, the timing of surgery can be earlier. So in conclusion, the negative impact of tricuspid valve failure on outcomes in adult congenital heart disease is increasingly recognized. In these patients, tricuspid valve disease is mostly regurgitant and often acquired, and long-standing tricuspid regurg is associated with RV failure and reduced survival. Thus, prevention is the best option, and efforts should be made to avoid secondary TR, either due to chronic elevated cardiac loading conditions or due to the distortion of valves during operations and interventions. There is no established evidence base to guide the indications and timing of tricuspid valve surgery in this group, and also many patients with TR are asymptomatic. So MDT discussion supported by serial multimodality cardiac assessment is currently the best available tool to look at the indications and timing for surgery. Surgery should be earlier rather than later to prevent right ventricular failure, and tricuspid valve repair is the best option and guided by understanding of mechanisms of tricuspid valve malfunction. Thank you for your attention.
Okay, can people hear me again?
I can hear you, Andreas.
Great, thank you. That was a very interesting talk. Thank you very much, Karen. Very stimulating. I would like to ask you a question as far as other indicators that you think might be useful as far as choosing the timing of isolated tricuspid valve surgery. Do you think any atrial function modalities might help or might guide you, or have you stayed away from those?
If I understand your question, you say atrial indications. I think it would probably be best to do it when the patient is still in sinus rhythm, because the atrial kick is really important. And it also means that if you leave it until you have AF, you will have much more advanced RV dysfunction, because the atrial fibrillation is quite often related to the volume load, which then means there has been very long-standing TR.
Okay, what I understand what you're trying to say, but what I was referring to more was things like atrial strain, so more kind of functional, contractile function of the atrial chamber and changes in that. Have you had any experience with that as far as your local practice in Leeds is concerned, or you don't really use more kind of academic tools in that sense that haven't really established very well in clinical practice yet?
We don't. We predominantly look at we try and quantify the amount of regurgitation, and then particularly try and assess right ventricular function, and serial imaging, and seeing an increase in the RV size and a decrease in contractility is really what guides us.
And the last question I have is have you got different views on different age groups as far as tricuspid valve surgery is concerned?
So this talk focused on the adult congenital population. I think generally, if you talk about isolated tricuspid valve disease of any age, it's the earlier the better, but obviously it depends on your level of confidence that you can deliver a good repair. And if a valve is very difficult and there is an appreciable risk that the valve may have to be replaced, then I think the operation should be deferred. And looking in the question and answer, I also sort of see that there is a question with regards to the use of cavopulmonary shunts. And I think it's a really good one, because I think the addition of a cavopulmonary shunt can be really, really useful, either if you're going to end up with a small tricuspid valve orifice to achieve a competent valve, and you will then divert the volume coming back from the SVC directly onto the pulmonary artery. Or alternatively, if the RV function is very poor. But that also means that when you do your assessment preoperatively, you have to make absolutely sure that the pulmonary artery pressures are low enough in order to do a successful Glenn shunt.
Okay, thank you very much, Karen. Does anyone else have a question for Karen?
So I'm looking at the chat, Andreas, and it also says, what about a reduction of the size of the atrium? And I think that is, again, a really good point. I'm not quite sure if atrial reduction will reduce the risk of getting atrial fibrillation if the patient is still in sinus rhythm preoperatively. However, I think if you have a very large baggatrium, it would sort of practically make sense to reduce that atrium in size, because if ultimately you were to end up in AF, then I think the risk of clot formation is less, and you may also consider amputating the right atrial appendix again in order to reduce clot formation or the risk of clot formation in due course.
Okay, and I see that there is one quick question still about the role of tricuspid valve repair in redo pulmonary valve replacement. Would you like to give your views on that, or shall I give my views on that? Please go ahead, Karen.
It's a little bit of a minefield. I think whatever the answer is, we have to see that over the lifetime of a patient and reducing the number of sternotomies. With regards to the TR, I think there are two elements. The first thing is, if there is TR and the patient needs some pulmonary valve and is suitable for a percutaneous pulmonary valve, would you go for surgery because you want to correct the TR as well? I think if there were to be severe TR, I would do that. If the TR is moderate, I would probably wait and see what happens when that new percutaneous valve has gone in. But the literature, as I said in my talk, indicates that if it was severe, then you will end up with marked long-term residual tricuspid regurg. The flip side is that when you repair the tricuspid valve, you may narrow the valve a little bit, and I think the valve will become definitely more vulnerable to injury for a future percutaneous valve. So the timing, I think, of your surgery and intervention, I think, has to be discussed in a multidisciplinary team, looking very much at the lifetime need for surgery, particularly for pulmonary valve replacements over time.
And I guess the other thing that I would add to your answer is, I think I would also make it dependent on how big the tricuspid valve annulus is, because the bigger the tricuspid valve annulus is, the less reverse remodeling you will see with volume unloading of the ventricle, in which case you might still be left with significant residual volume loading from tricuspid valve regurgitation. That would be another reason to consider doing a tricuspid valve repair concomitantly. We are close to 12. Unless there are any urgent questions, I would like to thank both speakers and the Society for this session. I hope you all enjoyed the talks, and thank you for our overseas participants as well for keeping up with us, and I hope you enjoy the rest of the meeting. Thank you very much.
Bye.
Bye-bye.